And this is a very interesting topic that Mr. Condello is going to talk to us about. How can the MiECC be applied in patients undergoing minimally invasive mitral valve surgery? Mr. Condello is a chief perfusionist from the Bari University Hospital of Italy.
Thank you so much, everybody. It's a great pleasure for me to introduce this presentation. I am very proud to share this innovative way, is an innovative concept that I think that in the future will improve our clinical practice. It's a really simple application of tips and tricks to improve the problem that we have today about Gauss's microembolic activity for endocavitary suction. In particular about minimal invasive cardiac surgery for mitral valve repair. And in this context, the state of art in intracardiac suction for mitral valve surgery was conditioned by the use of some aspirators. No, we know all this system. No. Nevertheless, the positioning of these aspirators is in the upper left pulmonary vein or right pulmonary vein, and depends on the typology of a surgery. In this context, we observe that the problem and the main limitation are about the increase of delivery of gaseous microembolic activity, the increase of carbon dioxide, and the increase of hemolysis through the use of these aspirators. Is not a good option for the use of MiECC with artificial venous reservoir. Is not a good MiECC, is not a MiECC, the use of this system. The main implications are about in goal direct perfusion, because increase the carbon dioxide outside the oxygenator. The increase of microembolic activity. We know all the deleterious effects of ischemia in the microcirculation and the damage from reperfusion. And if we use venting on pulmonary artery to prevent this, the 63% of patients that have effective drainage of the right section on the pulmonary artery have a return of oxygenated blood from the pulmonary veins during the cross-clamp time. Is important issue because most people say that if I have a good drainage from right cavity or put the venting in a pulmonary artery, I resolve the problem in the pulmonary vein. This is an important issue for the closed circuit and for extracorporeal membrane oxygenation. Today we have a problem of venting. The minimal invasive approach, I think, that improve with the extremization or maximization of biological impact all procedures that involve the circulatory support. The vision and the perspective is a correlation of minimal invasive cardiac surgery in mitral valve repair or substitution with minimal invasive extracorporeal circulation. With intracardiac suction without bubbles. This is an example. No, you see that. This is the two vents, one in aortic root and the other in pulmonary vein. How it is possible? We use, in our experience, this cannula, that is a retrograde cannula for cardioplegia. We put this inside the venous pulmonary vein, and we use many tests, the right test, to assess the use of it. We start with the heart of pig to improve the isolation of pulmonary vein, and we try to simulate this in vitro. This is our circuit. This is the two pulmonary vein. We put inside the small tubing. We use a manual insufflation inside the balloon in the first of all, in the seconds. Okay. We create a venous reservoir with liquids in continuity with our MiECC. Okay. We control the pressure, and we start with the aspirators of the liquids from the venous reservoir. In this context, it is a pulmonary venous return. We open the venting line in continuity with our bubble trap without extracavitary cardiotomy, increase the RPM, and we observe that there is a very beautiful, effective suction. So, we start in this context, and now we are in semi-final for ISMIX. We just arrived before 3 prize for innovative idea with low cost to improve our clinical practice. The limitation of this cannula is the shape, the small cannula diameter, and the potential visual clutter on the surgical field. For this reason, we developed a patent to improve the design of this system, to become really feasible, to improve our clinical practice in all surgery, not only on MiECC, because today we have a mitral valve repair with conventional extracorporeal circulation in mix. Yes, okay. But the aspirators of SAMP is really pro-inflammatory, pro-embolic. This is a system that I think that improve all surgery. The system is this one. We idealized with my head of cardiac surgery. This approach is really simple. We use a 1 balloon, 2 balloon, 3 balloon, or 4 balloon inside the pulmonary vein. It's possible to use 1, 2, 3, or 4 in relation to the visual. And the system is a composite device that have a disposable and a monitoring system. And the only problem of this idea is an implantable device and is a class 3 for normative of MDR, medical device regulatory. Nevertheless, it's really important that today I share our preliminary report with disposable that we have all about retrograde cardioplegia to improve the management of the mix procedure. And I concluded my presentation. I not explain more details about this presentation because we have a competition for ISMIX that we have on 30 May. And I presented the full work in Athens the next 20 days. Thank you so much for your attention.
Thank you very much, Ignacio. That was a very interesting and a very impressive presentation. It looked a little bit complicated for me, but Mrs. Jansa from Toronto would like to comment and ask you a question.
That was a great presentation. I think it really focuses on an area that is a big topic of contention when we're trying to do minimally invasive with MiECC. I was just wondering if you guys had done any research into what kind of flows you're actually getting through this venting mechanism, given the fact that it is just gravity or draining directly through the pump.
Is a good thing. In our perspective, this approach is for all typology of aspiration with roller pump, with passive drainage, with Venturi effects, or for the use of inside the inlet of the pump. Is important the monitoring of negative pressure inside this needle to assess and regulate the suction. We think all, I start with this society that I have 24 years old, and the perfusion is my mission, and it becomes that these items is the principal limitation for the company, no? The company develop devices such as the hybrid reserve, but today we focus on the cannula, on the endocavitary aspirator. So this is my perspective, but I think that all perspectives are really useful to improve MiECC, to extend in all procedure. That the first of all limitation is the bleeding, the blood loss. If together with the company develop a system to do it, we extend really MiECC.
Thank you.
You're welcome.
Thank you very much.